This is the panel on finance. You may recall Mark this morning, Mark Diebold, mentioned the financing component, and he made a few points I want to reiterate now before I turn it over to the panel. The first point he made is that we talk about innovative finance, but really a lot of what we're talking about isn't so much innovative, but it's something that has to be done that in many instances isn't being done. And part of what we need to talk about is how we can get these things to happen. I mean, a lot of people, when you talk about innovative finance, you think there's a printing press in the back that can print out all the money you need if you call it innovative finance. And in fact, that's not what finance is about at all. What we're trying to do is tap sources of financing that haven't existed before. Some of those are sources that potentially can come from external to most countries, but the large sources, the big dollars, are what exists in countries already. And a lot of what we're trying to do with the financing mechanisms we're going to discuss is trying to figure out how you can create both economic and political momentum around a financing vehicle that can bring the resources necessary to accomplish the goals. And the other thing that Mark mentioned in his talk was, a lot of the solutions that consume most of the bandwidth out there are solutions that are created in the developed world that involve a heavy dose of financial engineering that result in a lot of transaction costs and don't move a lot of money. And in fact, one of the things that came out from our Nairobi discussion was that there are already solutions being implemented in the developing world that are moving real dollars, and we should focus on how we can accelerate and augment those rather than coming up with new mousetraps. So this whole session was built around the idea of listening to the voices of the people who are actually implementing things in the developing world. And the last point I'll make before I turn over to Jonas is that a big other outcome of our discussion in Nairobi and the financing element of this report was the tie between what we need to do to generate finance to meet the 90-90-90 targets and what we need to do to generate finance for UHC. And that the big sources of money are largely going to be coming around UHC. And therefore, if we're going to build sustainable financing for HIV, it has to be tied into UHC. And that's a good thing in terms of the fact that there's a lot of energy and momentum around universal health care. It's a challenging thing, and Carolyn, I think, will talk a little bit about this, in that so much of what we need to do on the HIV side needs to be done in a differentiated and bottom-up manner that may not be amenable to a purely one-size-fits-all top-down solution. So without any further more ado, let me turn over to Jonas, and he can talk a little bit about what's happening in Thailand, and then we'll move on to Vidi and Carolyn.
Thank
Jonas?
you, John. Are you there? Sorry. Okay. So I'll actually be talking about the experiences of some Southeast Asian countries on universal health coverage. I'll begin with a short walkthrough of what UHC is, because I feel that since this morning we've been talking about universal health coverage, and it'd be good to have a common understanding of what it really means. And then proceed with the realities on the ground, our own experiences in Southeast Asia on UHC, and then present some opportunities and challenges, especially in our conversations around integrating our HIV response into universal health coverage. Okay, I think even in this conference, UHC will become one of the buzzwords. UHC is on the ascent. And the momentum has, in a way, reached a critical turning point with the inclusion of UHC as a global development target. And it's also critical because it also locates healthcare within the context of other development agenda in terms of eradicating poverty, for example, or in terms of building resilient and sustainable and inclusive societies. But the promise of UHC rests on the idea that we can actually expand healthcare, include more people into the system, expand the kind of services that are being provided while reducing the costs, rests on that aspirational framework. And countries have their own means and mechanisms on how to achieve universal health coverage. But it requires many things. The first one is the creation of viable risk pools, creating groupings of individuals with different health risks and asking them to prepay for their health needs so that we share the burden. No one suffers individualized, catastrophic financial costs because of their health needs. The second one is that it requires political consensus. And this morning, Ambassador Briggs talked about having a shift in our community philosophy around healthcare so that we're able to include the HIV response. And UHC has to navigate this political consensus, this shifting political consensus. I think it's important to realize that a lot of necessary tension goes into the creation of universal health coverage. Tension between, your actuarial mathematicians and the board members of your insurance schemes, between politicians and voters, who gets covered, what kind of services get to be included into our own universal health coverage schemes. The third requirement is the need to scale up public investment. Public investment is critical for the success of universal health coverage. And without public investment, one can actually say and determine that universal health coverage should be mediocre. And here, public investment is not just a source of financing, it also plays a regulatory role in terms of saying which population, for example, should be included into universal health coverage schemes, or to determine what kind of health services should be supported and established by the state to make the whole scheme viable. And lastly, it requires a continuing expansion. So it's not, a lot of countries are announcing that they've already reached universal health coverage, but I think it's important to realize that it's almost virtually impossible to reach universal coverage. It will always be a struggle. And it's important for countries to keep on expanding health coverage to make sure that we're able to address new epidemics or to cover new technologies to address epidemics. In Southeast Asia, I think I'll just present some, I suppose, key points, some of our observations in the region. Within ASEAN, UHC is seen as a priority by members of the Association of Southeast Asian Nations. Countries have different financing modalities for their universal health coverage. Some have multi-payer systems, compulsory and voluntary contributions. Other countries earmark certain revenues to finance their universal health coverage. For example, we have the Philippines earmarking revenues coming from taxes on alcohol and tobacco to finance universal health coverage. In Thailand, they also use their revenues from alcohol and cigarettes to fund programs for non-communicable diseases. So there are many, many innovative mechanisms that countries use to finance UHC. Countries also have varying levels of inclusion in terms of their HIV response. What kind of HIV services are covered or funded through universal health coverage. Despite the prioritization of UHC in Southeast Asia, direct cost still remains high. That figure, this image actually reflects the level of direct payment for healthcare in the region. So the darker the color, the higher the direct payment for health. So if you zero in out-of-pocket payments. So if we zero in some countries, for example, Malaysia, which launched its UHC in 1980, reports near universal coverage with 95% of the population covered under UHC. It has no insurance mechanism, but the federal government subsidizes healthcare. However, private health sector plays an important role. But that reality also means that services are quite expensive in Malaysia. So if you go to government facilities and they are subsidized by the government, but if you go to the private sector, of course, you have to pay more for these services. So out-of-pocket remains high. The scheme covers HIV testing, viral load and CD4 testing, ART, STI, and opportunistic infection screening and treatment. The Philippines started its scheme in 1995, and at the core of the scheme is a social health insurance called PhilHealth. It's a mixed scheme with government subsidy, social health insurance, voluntary private insurance. Similar to other Southeast Asian countries, out-of-pocket expenses also remains high. And for a premium of less than $50, I'm sorry I wasn't able to put that in the slide. Around, I think, $600 worth of HIV services are covered under the scheme. And you also get subsidies coming from the national or local governments to pay for the premium contribution for universal health coverage. What's covered in the package are your ART, other HIV meds, viral load, CD4 testing, professional fees for doctors and other medical professionals. We have a speaker, I understand we have a speaker from Indonesia who can go more in detail about the universal health coverage scheme in Indonesia. But like the Philippines, Indonesia also has a mixed scheme of having a social health insurance and direct government subsidy for healthcare. Contributions coming from, or the role of private sector is actually significant as well in Indonesia. Direct payment is also high, like the other Southeast Asian countries. And most of the HIV services are covered except HIV treatment, which gets direct subsidy coming from the government and support from international donor. The price of HIV medicine cannot be accommodated under JKN, the public insurance for Indonesia, because of weak regulatory or procurement mechanisms in the country. Sorry, this should be Thailand. Not Indonesia. Thailand is a front runner in universal health coverage in Southeast Asia. And it has, sorry? And it has launched its UHC scheme in 2001. It has several schemes, actually. One scheme for government employees, one scheme for the private sector. And those who do not fit in both schemes go through the scheme managed by the NHSO. So HIV services are supported through the NHSO. The target is to reduce direct payment to 30 baht for all diseases in all government hospitals. They're reporting no out-of-pocket payments for HIV services supported by NHSO. And what's interesting about the scheme, one of the schemes in Thailand, is that they're actually paying for services being provided by community groups. So they're actually procuring or purchasing services coming from HIV key populations. They're supporting a few sex workers organizations right now, and also a few MSM organizations. And a lot of these decisions are actually happening not at the national level, but at the subnational level. What's common across these countries is that to a certain extent, there's criminalization of certain behaviors, of varying levels of criminalization of behaviors of key populations, and yet there's also space for engagement. Especially at a subnational level. And that's reflected by, and that's, I think, largely due to the fact that health systems in these countries are very much deregulated and decentralized. So what are the lessons? I think the first one is that UHC is important for sustainability, but we shouldn't, especially for recurring costs that can be absorbed by the system, but we shouldn't see it as a magic bullet for the HIV response. And as a framework, it demands for inclusion, but the conversation on the ground normally uses economic metrics for inclusion. We have to reframe the conversation and make sure it's around equity, not just because you're poor, but because you're excluded for many factors, for social factors, for instance, or because you're criminalized. Another point that I'd like to raise is that even this morning, we seem to talk about UHC as if we need to integrate, otherwise the response wouldn't be sustained or we will perish. I think these are false choices. I think if you listen to the conversations happening on the ground, there are more pragmatic considerations. People think that we can integrate where it makes sense, and there's still space within this aspirational framework for programs that are supported through UHC but delivered vertically. So it's not either or. I think countries can shape how they want to achieve universal health coverage. I've already mentioned that in Thailand, for example, UHC is procuring services coming from community groups. And I think that's something that we can learn from and understand how community systems, in a sense, can be integrated into universal health coverage. The last points I'd like to raise is really about governance. We've been talking about, this panel is essentially about innovative financing. But innovative financing can only happen, especially if we're looking for financing for programs for key populations, if we also have innovations around participation. It won't happen overnight. It's something that we need to somehow find spaces for in how public health systems are financed, and make sure that communities are part of that conversation. And that would require innovation in participation. There are examples coming from the region. For example, in the Philippines, for example, one of the programs that launched by the previous government was a bottom-up budgeting mechanism where community organizations can participate and propose programs to the government. And this would include, for example, allocating resources to subsidize certain populations into the country's universal health coverage scheme. And lastly, donors also have a role on UHC beyond financing. It can incentivize governance mechanisms that are participatory, for example, or it can incentivize UHC schemes to understand how it can actually support or finance community-based programs. So these are innovations, I think, that can be explored through the Universal Health Coverage Scheme. I'd like to end by saying that a few months ago, there was an initiative in Asia-Pacific, in our region, launched by APCASO, by ICSS, and by GFAN Asia Pacific on the UHC that we want. And I have some flyers outside that, in a way, provides guidance to advocates on the principles that we should be using in engaging governments to make sure that we achieve inclusive universal health coverage schemes. Thank you.
Thank you very much, Jonas. And in fact, if you could put that slide back up, I think that slide actually articulates many of the conclusions that came out of the financing section of the report. Okay. We'll have time for questions later, but there's one point of clarification I wanted to ask you. It seems a little that bullet point number 1 and 3 are a little bit in conflict. Your point that UHC is key to sustainability, and yet we don't have to integrate. How do you resolve that?
I think the principle really is to integrate where it makes sense, because you also have to make sure that the schemes are viable. There are financial considerations to make sure that that they can continue. For example, to make sure that JKN remains financially viable. But that doesn't prevent the government from directly subsidizing certain programs and establishing vertical programs. And we should look at, in a way, taxation as a form of prepayment. It's not part of your insurance schemes, but then when you earmark certain revenues for particular services, then that really is it's another form of prepayment.
Thanks a lot, Jonas. We'll explore this obviously a lot more during the Q&A. Vidi?
Yes.
Yes, this should be it.
Yeah, thank you. Test. Good evening, ladies and gentlemen. I'm about to present you the implementation of HIV treatment and prevention in program in Jakarta. I would present you a short information about Jakarta demography and epidemiological profile. Jakarta is the capital city of Indonesia. We have 10.2 million of citizens reside in Jakarta. The population density is 15,328 per square kilometer. The mobility in Jakarta is very high. We have 3 to 4 million of citizens from outskirts of Jakarta commuting to our city to work in daily basis. Jakarta has 5 sub-districts and 1 regency. There is Central, East, West, North, and South Jakarta, and Thousand Island Regency. Jakarta has 44 sub-district primary healthcare and 305 sub-district primary healthcare, and 177 government hospitals that serve citizens covered with national health insurance. For the HIV services coverage, we provide easier access of HIV service to public and key population in primary healthcare and hospital ranging from ARV drug and lab facilities. This is the trend of HIV and AIDS reported cases ranging from the year of 2011 until June 2018. The number of both cases seem to be decreasing, and we are trying hard to identify HIV case much earlier to prevent the development into AIDS states. This is the overview of HIV case based on age, sex, and risk factor in this year 2017. The key population for HIV case are mostly in MSM group. This is the distribution of HIV cases by district. We got this data from Ministry of Health of Indonesia. Most of the HIV cases occur in Central Jakarta, but this report could be biased because this is the data reported from health facilities, not from the patient domicile. So we need to review this data thoroughly. This is the short profile of key population in Jakarta. From the maps, we have both hotspot population and key population. Almost all of key population is secreted on sub-district. Therefore, where we provide easier access to HIV service in our healthcare, especially our outreach patients. A fast-track commitment to end AIDS has been signed by Governor of Jakarta in 2016. I would like to present the progress of our fast-track response. For the target of fast-track response, we have a national target made by MOH. We have 3 targets or 90%. The estimation of PL-HIV in Jakarta is 109,676. This is the HIV on before after fast track. The target of HIV test is increasing than before. With cross-sectional cascade, we identify our performance to reach this target. There are several gaps identified in this picture. For the HIV positive, we only reach 54%. For the ERV target, we only reached to 22%. For the 30 target person, we have performed viral load testing for 1,920 PL/HIV. From this test, 92% show viral suppression. For health promotion and disease prevention, condom, clean needle and syringe, optimizing cadre as communicator to the citizen, harmonization between programs, sex education in school, blood screening using nucleic acid with Indonesian Red Cross. For first 90% target, optimizing under our standard based on minimum standard of service. This is a national regulation. Mobile testing, nucleic acid testing, early infant diagnosis, HIV screening among TB patient and pregnant mothers, premarital medical check-up, NGO networking with key population, government sector networking, and partner notification. For second 90%, test and treat all early start of ARV, 100 covered for antiretroviral therapy in primary healthcare, antiretroviral stock information, hospital availability for antiretroviral drug and referral. For 90%, viral load testing expansion, specimen transportation, and development of viral load testing in health facility. We have several financing from so many sources. For regulation section of provincial head office, we have our funding source from national budget, local budget, international grant, and CSR. For supervisor section of district head office, we have our funding source from local budget, international budget, and CSR. For primary care and secondary care, we have our funding source from local budget, international grant, CSR, and Public Service Agency or BLUD. Public Service Agency fund is in the district primary health care and its use is more flexible compared to other funding. District primary health care already utilize this for promotion and prevention HIV program. 69% fund is from local budget and public service agency. 16% is from national funding and 15% from international grant. The fund is allocated based on the healthcare needs with the major source from local budget. We have several resolution. Jakarta, a special capital region, has high mobility of people coming from outside Jakarta, resulting in the following. High mobility of key population, which makes the mapping is difficult, and size estimation is hardly accurate. Jakarta Hospital, the main center of referral, so most of the patient that are centralized. Loss of follow-up patient from outside Jakarta had to be reached out. Hidden key population, particularly MSM, JKN register or National Health Insurance Register is really different with System Information HIV/AIDS Register. The system is really different where National Health Insurance using ID number and SIHA use Unicode. The calculation of health coverage is a bit difficult because of double registration, but we managed to resolve that. A catchment area approach. Using ketuk pintu layani dengan hati or door-to-door service program for better coverage. Outreach worker to work in synergy with KPLDH team. One team KPLDH consists 1 GP, general practice, 1 nurse, and 1 midwife. Optimizing local budget, CSR and non-bending grant of capacity building. Procurement of medical equipment via e-catalog. Integrated health service and promotion post or pospindu. Health curriculum and educational institution. Public figure involvement or city ambassador to encourage the importance of HIV test in Jakarta. For better view of our progress, I would like to present a glimpse of our activity through a video. Sorry.
We might be getting some technical help on this.
Oh. 1 minute video. Sorry. The end. Yeah.
There's no sound. Okay, is there sound?
No.
Okay.
If the computer's not hooked up to a sound, it may. Is there sound with this video, Vidi? Oh,
Yeah.
excellent.
Oh, yeah. Okay. Thank you for your attention.
One question, Vidi, while you go back to your seat. You didn't mention the private sector in this scheme. Is there a role for the private sector at all in this? Yes, please. Yeah, we can hear you.
Bagaimana peran dari pihak swasta dalam membantu ya, terkait dengan skema finansial?
Okay. In Indonesia, ditranslate ya. Ya, karena gubernur sudah komitmen dan kami mempunyai peraturan daerah di Jakarta, tentunya ada beberapa pihak swasta yang dimintakan untuk CSR dalam hal partisipasi dalam hal bidang screening di Jakarta melalui tes HIV kepesertaannya.
Okay, so because the government of Jakarta, they have rules that ask the involvement of the partnership from the private, especially for testing. So they have the CSR that help the government to help on the testing.
Thank you. Carolyn?
And you can click with that one, or you can click with that one.
Okay, that might be better. Okay. Always good to be last, because you can build then on what other people have said. So I'm going to give you a tale of 3 countries today. And all 3 countries in the Caribbean, if you add up the population, we aren't actually having as many people as Jakarta. But I think some lessons can be learned from it. And I hope that we will be able to answer some questions at the end of it. I don't have any conflict of interest here. And I want to talk to you a little bit about 3 Caribbean countries. The first one being the Dominican Republic. And my talk is actually not focused particularly on how you finance, because most of our countries theoretically have universal access to health and universal health coverage. What I'm going to talk to you about is the role that civil society can play specifically in the HIV response. And I'm going to use those 3 countries. In the DOMREP, there's great cooperation between the National Coordinating Body, which is CONAVIS-ZEDA, and those of you who have spent any time interacting in this response would have met members of CONAVIS-ZEDA. And they're very engaged. They are set up early in the response, have been operating, and have been leading the charge. But they've also brought in civil society from very early, and there's excellent leadership on both sides. And because they're Global Fund eligible, this leadership has translated into a strong CCM with leadership from civil society as well. And today I want to talk to you a little bit about a particular clinic, and that's not COIN, that's COIN, El Centro de Orientación e Investigación Integral, which offers services to key pops. They actually started out with advocacy around drug criminalization, have expanded tremendously and began offering clinical services some years ago. And they function as a government clinic. The government pays them to deliver services, but with their extras through programs supported by donors. And I wanted to just very quickly take you through this, because we're not lingering around data. But when you compare the cascade for the COIN clinic versus the national DR cascade, you get some impressive distinctions, particularly around the rate of viral suppression. The clinical services are offered mostly to MSM and trans, but they're also available to other members of key populations, including sex workers, with a particular focus on trans sex workers. And their cascade for trans is, in fact, as impressive and better than their MSM cascade. Jamaica, where I'm from, strong civil society leadership in the AIDS response. Jamaica is now becoming an upper middle income country, transitioning away from the Global Fund. But from the beginning, there was good leadership of the response, the setup of a National AIDS Commission, and for a while, a bit of turmoil on the CCM, because the government had to be, while the key populations and civil society were involved, the government's control of the CCM had to be pried from them. Because at one point in time, the chairman of the CCM was also the chair of the National AIDS Commission, which was the secretariat, and was also the lead person in the Ministry of Health, which was the PR, and resisted civil society intervention. But there is great coordination now, driven initially through civil society activism at the CCM. Civil society actually had to set up a body of coordination for civil society in order to bring a united response to the table to ensure that civil society was getting the role it deserved at the table. And so they actually set up the Jamaica Civil Society Forum for HIV/AIDS, learned all they could about the mechanisms available to them to be more of a forceful voice on the CCM, which is a space, the only space really at that time that acknowledged the role of civil society and the need for key population inclusion. And I'm going to tell you a little tale today about a Jamaica AIDS Support for Life, known as JASL, which actually predates the national response to HIV and AIDS. It was a group of friends. It was founded by Robert Carr, who many of you will know personally or have heard of, would have known, because unfortunately he's now dead. And it consisted in the beginning, before there was anything else, with providing hospice care to dying friends who the hospitals would not take, and has grown tremendously over the years to become a force to be reckoned with. And now a partner with the national response. JASL operates 3 clinics across Jamaica and provides clinical services, including safe-sex commodities promotion, STI services, antiretroviral therapy prescription. It manages opportunistic infections, other health conditions, diagnoses, diagnostic support, lab support, gender-based violence screening, and offers support services as well, including nutritional support, cash transfers, individual counseling, disclosure counseling, life skills, home and hospital visits. Hasn't arrived here overnight, got there through a long series of work and heavy involvement, but with tremendous support now from the National Ministry of Health and the National Family Planning Board Sexual Health Agency, which actually drives the AIDS response in Jamaica. And the results, not only are JASL actually treating, but they're also a referral center for a number of other NGOs that work in prevention and testing. They have 522 clients in care. In 2016, of the 161 newly diagnosed, 55 of them were MSM. 121 were linked to care, of which 43 of that, about 1/3, were linked by other CSOs. And they had a 98% retention in care. And they had a 40% viral suppression from all their services and treatment. Viral suppression in the national figures is 21%. So they have a significantly higher viral load suppression. My third country I want to tell you about, and perhaps this is the whole point of my discussion, that finance is not enough. Money is not enough. Trinidad and Tobago, and I need to correct my slide, I apologize, it is not an upper middle income country, it's an upper income country. Averages GNI of about 16,000 per year, and it goes up and down depending on the price of oil. They never were Global Fund recipients. They just were always too wealthy. And they're a country of 1.8, 1.9 million persons. You would think that they could get it together with that level of income to treat their AIDS response. But they haven't been. Only money that comes into them is through a small channel, through regional grants. CVC, where I used to work, we did a significant amount of subgranting to small NGOs in Trinidad. They've had many, many iterations and renamings and recreations of their national AIDS bodies, with minimal civil society in any of them. And there was a period of about 4 years when it didn't matter what you called it, it didn't meet, it didn't have a chairman, and there was no coordination. And Trinidad persists in the treatment silos and fiefdoms that have kept our AIDS response in trouble. There are a limited amount of persons allowed to test, so none of them were civil society outside of the Family Planning Association. You need to show ID to get tested, which is really useful if you're looking for homeless drug users. And MSM. Until last year, only 4 or 5 treatment centers for actual full-blown HIV or AIDS. Even prisoners were brought to the AIDS clinic, as they are called, as prison doctors were not allowed to treat. So you had this horrendous paradigm of people in shackles with holding onto a file that said prisoner, waiting to be treated in a clinic that's treating somewhere around 7,000 or 8,000 people. And the minute you walk through the door, everybody and his wife knew what you were going in there to get treated for. And a civil society that's completely disengaged and hopeless. stockouts are more frequent in Trinidad than they are in either the DR or Jamaica, as is loss to follow-up, and their cascade is actually not available. So I want to conclude with some questions for us, and I want us to come back to John's focus on financing. What role did the Global Fund insistence on civil society representation and its ability to leverage its funds to ensure effective systems are in place play in those three stories? What role did enlightened and empowered leadership at civil society play, and how was it engendered or built? And what lessons can we learn from these three brief stories? Because quite frankly, if we had all the money in the world and we didn't spend it properly and effectively, if we didn't engage with those who can reach and retain and bring to viral suppression the populations that we're having a hard time finding, then it would have been all in vain. Thank you.
Thank you, Carolyn. Carolyn, I think your point, which I heartily agree with, comes through loud and clear that the engagement of the Global Fund is a big part of providing support for civil society to play the value-added role it played in Jamaica and in Dominican Republic. But was there something else about the financing mechanisms at play in those two countries that helped create the dynamic you described?
None at all. Trinidad and Jamaica inherited the colonial health systems that provide free health care from cradle to grave. And the Dominican Republic, I'm not going to talk off the top of my head, but the Dominican Republic does support public health care. So it's not the finance bit that it's not the access to health care, it's not the universal health coverage that is different. It's whether or not a government has the political will, which can be naturally born, I guess, but quite often is helped to come to birth by a little pressure from outside, you know, a little drip of pressure. And I think in this case, the Dominican Republic perhaps less so, because CONAVISITA was a creation of the government, and it was built, and then the CCM was built around that strength. Jamaica, certainly, the door opened because of Global Fund leverage through the CCM.
Thanks a lot. We have a little bit of time, about 5 minutes for questions, so I think these should start coming up from this squiffer thing. But before we get to these, I have one more question for you, Jonas. You had made the point that, innovative finance, and I think this is the same point that Mark made, that, we can't get attracted too much by the shiny object of innovative finance. It's important, but ultimately it's the underlying fundamental financial mechanism that needs to be in place for a broad support that matters. But what are some of the things that you saw that you've seen in Southeast Asia that have allowed innovative finance to be value added in those circumstances? What are some of the innovative financing mechanisms that you've seen that have maybe brought something to the table that just pure government financing or donor financing could not?
We've witnessed engagements with private sector, for example, to top up and get more resources, especially in upper middle income countries like Malaysia. They play a critical role as well. But what I suppose the space for innovation for many middle income countries is really because of the fact that as income levels rise, donor support is withdrawing too soon and too fast, while spending for healthcare is rising just slowly, and out-of-pocket payments is also declining very slowly. So there's space for innovation because of the gap created by these realities. Having said that, I think in our context especially, it's really in domestic financing where we need to focus on, because there's space, and it could be mixed. I mean, there could be many instruments you can use, but I think our eye should be focused on, our target should be focused on domestic financing, especially at a subnational level. I mean, we've seen in Indonesia, for example, the role that local governments play in financing health services. And I think civil society and community organizations are in a very strategic position to engage local governments to invest more for health.
Yeah, actually, I think that's an important point, and then we'll turn to these questions. But a lot of, when we think about innovative finance, we really ask ourselves what we're buying for the cost of trying to set up something new and innovative. And we think about, well, we're buying access to an untapped source of funds, and that's something that's good. Sometimes we're creating incentives for efficiency. But in my mind, one of the most valuable things you buy through an innovative financing mechanism, like a buy-down, for instance, is a on-ramp for countries to mobilize more of their own domestic finance, to create a political dynamic where they say, look, if someone's going to buy down a little bit of the debt, then we could put more money in. Because at the end of the day, when you borrow money, it's your money. It's not the lender's money. We have a whole number of questions here. A lot of them sort of run along the same themes. I know, Vidi, is there any particular question you want to address?
Yes, Jakarta mempunyai 10 juta lebih penduduk, di mana 98% UHC, 98% universal health coverage. Dari angka itu 50% bersumber dana dari APBN dan sisanya bersumber dana dari APBD. Kemudian yang penting di sini adalah tidak ada overlap pembiayaan antara sumber dana dari JKN maupun dari program.
So Jakarta, they have 10 million people. That according to her, that 98% of the citizen is covered by universal health coverage, and 50% of the universal health coverage is the financing is from the national, and then the rest is from the district. I mean from the province. So they can manage the financial with the condition if there is no overlap of the financing system.
Thank you. Carolyn, there's a question about Jamaica there. Will it successfully transition from external funding?
I have no magic window into this. I think it will be a challenge. While we acknowledge the health coverage, a lot of our HIV financing comes from the Global Fund. Government is covering a more increasingly significant percentage of the ARVs. I think they've committed to 100%. But most of the other service delivery by the community's key populations, the important things that make that difference in that barrel load at the end of time are funded by donors.
So let me ask a question to you specific to Jamaica. It sort of will encapsulate a lot of these other questions, then also get down to this political will. What is the political dynamic that, from your perspective, would have to change for, as those externally funded resources withdraw, would allow the resources within country to pick it up, either through direct public support or through some type of public-private or private sector support?
About 10% of our healthcare, of our population is insured privately. And Jamaica is coming out of a very bad economic situation where we had a 140% debt to GDP ratio, and we've been under an IMF program now that's reduced that significantly. We're now below 100%, but still struggling at 90-something% of debt to GDP. And so the actual amount of money that the government has and has the ability to put in is limited in terms of that. And they've done a really, I think, done as well as they can to provide the antiretroviral, to agree to test and treat, test and start. So they do actually have a few schemes for financing health from the taxes and from the lottery, and so we get additional coverage for drugs for the elderly, for chronic illnesses, financed through. But I'm not quite sure, given our economic situation and a situation of no growth virtually for 20 years, where we're going to find that extra money.
I think this is the fundamental crux of a lot of these questions, like the first question about few countries have hit their Abuja targets. How do you get political commitment? UHC finances a solution, but what's the risk of trying to do as much with the same amount of, how do we get more from the same amount of dollars? I think you have to acknowledge up front, you can only get so much, there's efficiencies that can occur, but at the end of the day, you can't do $200 million worth of service with $100 million worth of funding. Part of the answer, I think, is to identify the countries that can realistically take on more of the burden themselves and create financing mechanisms that make it politically possible for them to do those, and then identify those that realistically are in situations either because of debt distress or conflict or other reasons that can't, and make sure that there are other resources, external resources that are available. The good news is the vast majority of the developing world is actually at this point, according to the IMF, slated to grow quite robustly. So we're looking at 3.9% growth in Africa, 5 to 6% growth in Asia, 3% growth in Latin America, but in fact, for most countries in Latin America, from a much higher base. So there are resources available in the developing world to be tapped. We have to find the financial mechanisms, whether they're dedicated taxes, whether they're buy downs, whether they are more risk sharing with the private sector that allows those resources to be unlocked. Let me give the last. Oh, do you have something?
I was going to say, I think that the RMEI of the Regional Malaria Elimination Initiative has some, and I'm hoping it, really hoping it works, has some lessons that we may learn from in terms of how we can approach this.
Last question to you, Jonas. Given the UHC learnings in Southeast Asia, what's next?
I think we need to deepen our understanding of financing as an issue, as part of our advocacy as civil society, for example. It's not rocket science. It's a bit challenging. I mean, when we're doing budget advocacy in the Philippines, we were also training health officials, local health officials, who weren't familiar with how HIV programs are financed or how public financing works. But it's something that can be learned. We've witnessed transgender activists in rural areas, in fifth-class municipalities in the Philippines who are engaging local governments to fund their own programs. So it can be learned. But it's very important for us to be part of that process because we've been outside of that mechanism for so long. And we're being reactive to it right now because of donor withdrawal. But I think it's time for us to learn how financing works, whether your innovative financing streams or whether through public financing.
Hear, hear. Thank you very much, Jonas. Thank you, Vidi. Thank you, Carolyn. This is a great panel. And